often in an emergency setting, we're overwhelmed with a lot of information, a lot of patients at once. It's easy to maybe miss one of those little details. That happens to me a lot. And so having something that can tell you, hey, look over here, I think maybe you missed this. And then having the human still have the authority to decide, yeah, that's okay. That was a blip in the vital signs, or, oh, I did miss that. We should move this patient right away, is going to be a really powerful tool.
So, hey, I'm Brent Myers, the Chief Medical Officer here at ESO. I'm sitting with Dr. Remle Crowe at WAVE 2025. And the first thing I think we need to talk about is this notion of a patient-centered view in EMS. Historically, I think we have thought about EMS as episodes of care, except anecdotally, when you're in your own system and you know, oh, there's this one person that calls a lot. That causes problems on a host of fronts. One of those is we can't quantify who's actually calling, how frequently people are calling. And then it opens us up to the possibility of bias because it's an independent recollection of one individual, not a scientific view. So one of the great things we talked about here at WAVE is that now within ESO, we can give you the objective information about a longitudinal patient, how often people call. What's the most important thing we get out of that, Remle?
Hard to pick just one. There's a lot of really interesting questions that open up now that we can track patients, not just during their EMS encounter, but throughout the continuum of care. And not only that, how many encounters we see patients. So historically, one of the things that we track is what % of the population uses 911. Perhaps you can talk a little bit about that. And now that we can actually track not just EMS activations, but true unique patients, we see a very different number.
Yeah, it's true. I've given many lectures where I started with, it seems preposterous that 9.5% of the population has a time-critical medical emergency every year. Indeed, it is preposterous because it's not 9.5% of the population. When we think about EMS rolling down the street, the part that sticks with me every time with the new data is that 57% of the time, that ambulance is going to someone that's having a unique, meaning their once medical emergency. Said the other way, 43% of the time the ambulance is rolling down the street, they're going to see somebody that's already called 911 this year. And so it pivots the conversation. It doesn't mean that those people are inappropriately calling the ambulance, right? I think we're going to be very clear about that. But what it does is it helps us think about how do we best serve that population. And we design the system around the unique medical emergency. Trauma, STEMI, stroke, CPR in progress. That's what people think about the ambulance. But what is actually happening almost half the time is some other type of access to healthcare. There was a great editorial that was written probably 15, 20 years ago. Brett Alspin, I believe, is the guy that wrote the editorial. And the question was this. He said, we should stop saying, why do people call 911 to access the healthcare system? The question should be, why do they use any other method? Because this is great service. It's prompt. It's compassionate. These are really wonderful people that come to take care of you. And so people call it all the time. And now we can quantify that to say that 3% of the individuals create 16% of the call volume. And so how do we better serve that population? And again, it's not meaning they're inappropriately calling, but we're sending a resource that was designed for stroke, STEMI, CPR, and trauma for someone that's accessing the healthcare system.
Absolutely. And the other component of this, and things that probably keep medical directors up at night, is often it is appropriate to send an ambulance, evaluate a patient, and leave them on scene. The emergency department's not the right resource for everybody at every time. But one of the things that would keep us up at night is, what if I leave somebody in place who really should have been transported to an emergency department? And so we look at something called a 72-hour repeat encounter. And now we know that 6% of patients where we do not transport, we're going to be returning for those patients.
Yeah. And I think as the medical director, I would always worry about those, right? And again, this is where anecdote took over data, right? There would be the one or two persons over the entire time that you're at an agency that had a bad outcome, and therefore you worried about every refusal, which is 30 to 40% of all the calls, right? Don't actually go to the emergency department. And so what I would do in my mind is, well, if we take them to the emergency department, we've mitigated that. Right now we're good. Well, as it turns out, even if you go to the emergency department, there's going to be a 3% 72-hour return rate for EMS to go back to see those people as well. We've got to really study those in a little bit more detail. But what we do know is that they, in general, look like they did on the first visit, right? Their acuity doesn't deteriorate at the aggregate level. What we really have to figure out is how to identify that small group that probably should not be left behind, that do end up in that 1% bad category. That's going to be a challenge. We're up to the challenge, but we've got to think about how to do that.
Absolutely.
The other, thing that we think about is knowing what happened to the patient. So part of what happens in this 72-hour return is that we then know who gets admitted and we can follow those through because of HD, which is fantastic. But the other piece is that we know the dispositions of those patients. We know when you go to the hospital, not only were you admitted or not, we know if you were not admitted, where did you go? Did you go back home? Did you go to a skilled nursing facility? Did you go to jail? Did you go to mental health, et cetera? That's always been interesting to us. But I think the other thing we talked about here is a paper that just came out in JAMA Open, so it's free. Everybody can read it, about looking at socioeconomic determinants, rural versus urban vulnerability from a socioeconomic perspective, and how that impacts your cardiac arrest outcomes. And historically, that required a lot of manual work, right? We had to go to the hospital and talk about how you did. And I think maybe what got lost in all of this, because the paper's interesting, we'll talk about that in a minute, but the ability of the ESO data to actually tell you how the patient did from a cardiac arrest perspective with no additional work is a new thing. And I think that's going to be very beneficial, not only for cardiac arrest, but for all the patients. And so maybe we can talk a little bit about how we map those dispositions, how important that is.
Yeah, absolutely. So in the hospital data, there's not a standard like we have in EMS. Like NEMSIS has very clear categories and values that we should be using. In the hospital, there's a lot of variation. But at ESO, we have a group who has created these buckets of meaning for dispositions. So we know whether the patient was discharged to home or transferred to another facility, died, et cetera. And we're able to use those dispositions as a proxy for what was their outcome, not just in terms of did they go home alive from the hospital, but did they go home alive and neurologically intact?
Yeah. And I think this discharge to home being a proxy for neurologic status, while not perfect, is really good enough to help us think about the ways that we should think about policy and evaluation. And so with that background, the paper that we just published was really interesting in that my hypothesis going in, we were looking at rural versus urban, and that's where I thought the divide would be, that response times are longer and all of the things in the rural environment that one would think would impact the probability of neurologically intact survival from cardiac arrest. As it turns out, that's not the case. Right? The data actually tell us that it is your vulnerability of your community. It is how the socioeconomic status of the area in which you live is much more impactful than whether you are urban, suburban, or rural. And we've seen this in other parts of the data, but the signal keeps coming through that things that we thought impacted it or not, there's one through line in all of it that seems to be impactful. So what are your thoughts about that?
Yeah, I think this concept has been around for a while, that your zip code probably matters the most when it comes to whether or not you're going to survive a cardiac arrest. And it's not because of you physically live there. It's all the reasons why you live there. And these social drivers of health play a huge role in what your outcomes are going to be. And so I think it gives us as EMS a targeted area on where we should focus our prevention efforts, where we want to do things like CPR training. If we see an area where we know that there's going to be less bystander CPR, great opportunity to intervene preventatively. And so I think this just opens up a wide vein of future public health initiatives as well.
Yeah, I completely agree. And I think the other side of it is we should study, conversely, what's going on in some of these rural areas, because I was really shocked. My notion was, if you're in the urban area, I've got a fire department around the corner. They're going to bring the defibrillator, do the CPR, and that's going to be very different than the rural area where there's these long response times. And I think we presume those long response times. And what actually has occurred is these communities have figured out a way to have a first responder or whatever it is. So we need to to dive into how is it that there is not a difference, rural versus urban, because whatever they're doing perhaps is something we could replicate in these socioeconomic areas where we're seeing the difference. Because logically, you would think the rural nature of a call would be more impactful than the urban, but that's not what we found.
Absolutely.
I think we should talk about some research that's ongoing, and we always have to be careful, right? Because we don't want to talk about things before they've been peer reviewed. And we actually learned this during COVID, right? Because people were so worried about getting data out, they pushed it out early, and then they had to do some retractions because the peer review process hadn't been complete. And so we don't want to get it over our skis here. That being said, I think there's some really cool opportunities that we're looking at. So maybe we should just set the table.
Absolutely.
Right? In the emergency department, there is a score. It goes 1 through 5. ESI score has been around since the late 1990s. And it's more or less validated. I think people feel pretty comfortable with it. And the 1s and 5s are easy, right? 1 is shot in the chest, CPR in progress. 5 is very minimal complaint, stable vitals, all of that. So we don't need any help getting a 1 or a 5. That's obvious. The problem comes between 2 and 3. And 2 is a high likelihood of deterioration, probably shouldn't go to the waiting room, high risk abdominal pain, chest pain with a history, those kinds of things. And then a 3 requires a workup, but in general is not anticipated to have deterioration if they have to wait a few hours. And so making that distinction is really important. People at the hospital have a hard time doing this. People with a lot of experience have a hard time doing this. But that is how bed determination is made in the hospital. So where are we with this, and what are we comfortable talking about, and then where do we think we're going?
Sure. So there are organizations who are working on predicting ESI scores and evaluating triage as a whole. And one of those organizations is MedNation, who we've partnered with to do some research. And MedNation has an algorithm called KATE that helps nurses at the bedside predict whether or not this patient is an ESI 1, 2, 3, 4, or 5. The research question that we have coming into this is, what if we could get them that information even sooner, given that a substantial proportion of these patients are going to come in by an ambulance, and I'm collecting a lot of information in the pre-hospital setting? Could we predict that patient's ESI score potentially en route and let the hospital know? And so we have just started this research, can't dive too far into any results or anything like that, but it is an exciting space to say, we're collecting all of this information. How can we use it to provide that information earlier, improve the system of care, because it really does take a system to save a life, and help our clinicians?
Yeah, and importantly, I think that you bring up a great point. In the emergency department, the assignment of the triage score has no additional ancillary information. There's no lab available. So everything that's available to the nurse at triage is also available to the EMT and paramedic in the field. So it stands to reason that we should evaluate this, because it's not as if the ESI score is assigned with some magic hospital data that's unobtainable in the field. It should be the same. And so that's kind of what we're trying to figure out. Is indeed that true? And I think that's really important. The other thing to think about with this is, if we can also be assured of a 4 or 5, that opens up opportunities in an evidence-based way for the beginning of our conversation about patients that call EMS frequently. If they're a 4 or 5, their likelihood of deterioration is almost 0. And so those are folks where we can think about, should we do an alternative thing like telemedicine, or go to an urgent care, or do something else? But this gives us an objective way to identify those patients.
And I think this is an exciting time. This is a use of AI where AI can be a helpful adjunct. And I think it's important to keep in mind that this is an adjunct. It's not here likely to replace us, but this is a new way of doing clinical care. And often in an emergency setting, we're overwhelmed with a lot of information, a lot of patients at once. It's easy to maybe miss one of those little details that happens to mean a lot. And so having something that can tell you, hey, look over here, I think maybe you missed this. And then having the humans still have the authority to decide, yeah, that's okay. That was a blip in the vital signs, or, oh, I did miss that. We should move this patient right away, is going to be a really powerful tool.
Yeah, I think, we can think about one of the keynotes that was here, and one of the speakers said something that stuck with me. I actually immediately made the note as soon as they said it. And the phrase was, AI sees everything but notices nothing. And that, I think, is how we responsibly at ESO bring this forward, right? Because it's not replacing the clinician's decision support, but it is helping them see things that may not otherwise have been obvious. And so, to kind of bring this all home, I think the notion that I'm walking away with from WAVE this year is that the challenge that we have is that, as the medical director from Oracle said, the electronic medical record up to now has really just digitized the old paper record. The next 12 months are going to be the time where we actually take advantage of all of the opportunity, and we bring the efficiencies to the field. Ambient listening in the background. We've challenged everyone here at ESO that 12 months from now, we should be able to demonstrate a complete medical record where the keyboard was never touched. And once we do that, then we can really be in this space where we can, again, help but not replace the decision process of the clinicians in the field.
Absolutely. I think this is truly a way of getting us to patient-centered care and clinician-centered care, where patients and clinicians can look each other in the eyes and the clinician doesn't have to have their hands down on a keyboard. And it's a really exciting space.
Yeah, agreed. So as we close out from WAVE 2025, one of the things we look back on 2024 pretty fondly is that we've been on a journey for many years to improve the automated matching of the EMS record into the hospital record. And historically, that's been a manual process. And one of my favorite Remle Crowe quotes is, "You cannot make the calf fatter by weighing it more often." And we have been monitoring this match rate for a while without doing an intervention. And lo and behold, it didn't change. But once we did an intervention, it actually improved dramatically. And so we doubled the match rate in 2024. And to the point that today we are matching a record every 10 seconds. And so the beauty of that is that it gives us a volume of information within the data collaborative to be able to ask and answer important questions, to be able to feed a model for AI in a way that is informative and that allows our clinicians to have confidence in the model they're seeing. So, Remle, it took us a while, but I think we finally followed your advice.
We did. We changed the system and we have a different result now. We have taken the manual aspect out of this process so that it can happen in the background all the time. And we've seen the match rate improve drastically.
Well, I think it's great that we took the time here at the end of WAVE 2025. It has been a week, but so thanks for taking the time to be here.
Thank you.